Thank you, team Labour Congress, for giving me this opportunity to discuss the topics. And as you all know, most of the questions are for Paili sir only. Or otherwise, they have got good faith in him. That may be the reason why. Yes, sir. The first question: how long you can clamp the aorta? Maximum time when to take off the clamp if any injury happens to aorta.
How long to keep? We used to recommend that keep it for the minimum possible. Then that minimum got extended, and we had even occasions to keep it for 120, 130 minutes in one case. No problems, don't worry. What we do is, during theater, we have the DVT pump going on, and afterwards we give thromboprophylaxis. So don't worry too much about it. The other question is, will you release the clamp in between? I would say no. Once you have taken care of the stumps and the main observable bleeders, then you release it. And see if there are other bleeders, then you tie it off or coagulate it.
Then another question is regarding the breech delivery. Again, to you, sir, induction for breech delivery.
See, breech vaginal delivery itself, even spontaneous delivery, nobody is recommending. So induction is not that to be considered. Unless it's somebody who says, I am prepared to take the chance, then only you induce. Okay.
Then is there any special clamp available like for internal iliac artery ligation?
Internal iliac artery ligation, you need a right angle clamp, Mitster, not Mr. M-I-X-Y-Z. Mitster clamp is a right angle clamp. Make sure that when you buy it, it is relatively pointed, but not very sharp either. You get the two sides areolar tissue removed by running an artery clamp on both sides of the internal iliac. You can also lift up the internal iliac with a Babcock, but most of the time you don't need it. Just negotiate under the vessel like that, lift it up. And then feeding the suture material is important. Feed the suture material at the end of a clamp like that, rather than go with your finger, because then the operator cannot see what you are feeding. So at the end of a clamp, you feed the suture material to the open jaws, clamp, gently take it around.
And can we wait delivery in case of placenta accreta spectrum till 37 to 38 weeks?
I mean, if there has been no bleeding and if you are not concerned about a percreta, waiting up to 38 may not be that bad. It's okay. It may be all right.
Sir, in placenta accreta spectrum, when you go for cesarean section, is it wise to place the patient in modified lithotomy position rather than in supine position?
There are people who recommend it. There are people who do manipulations from below to push up the remaining cervical stump and all that. We don't do that. That is why we don't put it in that position. But it's quite okay, I would say.
Regarding vasopressin use,
we never used it, but of late we have started to use it when you try to dissect the bladder down. There are so many nitty-gritties that you gain as you continue to do more and more cases. And one of the points which I want to emphasize is, in all the visuals that we showed, the big chunk of vessels on the surface of the placenta that we saw, frightening vessels, many of them are really not frightening because they are just on the surface of the protruded placenta, and if it is away from the bladder, you don't have to touch it. You can see big vessels on the protruded placenta, which you don't have to touch. So it's important to outline the dome of the bladder, incise the peritoneum only just about a centimeter or so above that. Don't unnecessarily separate the peritoneum right from the beginning of where the placenta is extruded. When you are separating the peritoneum from the surface of the extruded placenta, again make sure there is a coagulum on the surface of that placenta. Don't break it. If you break it, then the blood will start coming, in spite of the aorta clamp and all that. So in case you accidentally break that coagulum, what you do is keep, these days in our disposable gowns, you can see some towel to dry your hand, which is not actually a cloth. It is again synthetic. That is very good to keep it there. You can keep it there, and if you have special clamps, as some of us have, you can even keep small things about saving blood loss.
One more, sir. Placenta accreta spectrum early diagnosis. Patient insists for MTP. What to do?
First thing to tell them is, MTP means at what stage of pregnancy it is.
Maybe around 20
Very
weeks.
early.
20 weeks, maybe.
Yeah, 20 weeks is a very touchy situation because if they are gone up to 20 weeks and if it is not recurrent bleeding, I would persuade her to, as we did discuss, persuade her to continue till a viable baby is available. After all, she has gone up to 20 weeks. But I do admit that 20 weeks is less hazardous. Able to take, have faith in you. I would try to continue till she is about, say, salvageable baby. But if she is insisting, I think it's not a bad idea if she has sufficient children to terminate even at 20 weeks. Because the longer you wait, more the bleeding, more the problems.
Okay, sir. Thank you, sir. Then next question falls for Dr. Uma. Can you continue use of the same prophylactic antibiotic?
So the subsequently you could have one dose would have been given. Subsequently you have a wound infection,
Yeah.
then you treat the wound infection.
So they are asking whether the same antibiotic they
if
can.
you're using cefuroxime
Yeah.
and in the context of a section infection, then obviously you would send off culture. Empirically you can start an antibiotic and then treat based on the culture.
Okay.
48 hours.
Empirically, you can start.
So generally
Or
that is
something
what
else.
you have used. So generally you don't use the same antibiotic.
Yes.
Yeah.
Okay, madam. Thank you.
And I mean, if you're having a lot of infections, the other point I want to make is you should audit regularly, see what is the organism, and then use that to dictate your antibiotic policy.
All hospitals should have an antibiotic policy. It's not. Thank you. And to Nushat madam, can chlorhexidine be used on mucosal surfaces like vagina for preparation for pre-op cleaning? Vagina is skin, no?
Yes, we can. We can use it.
Yes, it can be used.
Actually, Nushat, what they probably mean is chlorhexidine in alcohol.
All right.
Chlorhexidine in alcohol may not be advisable to be used over mucosa, but chlorhexidine in water is okay.
It's okay, absolutely.
And chlorhexidine already Nushat mentioned in the discussion about the skin burns that happen. This can happen with a 10% povidone iodine. This can happen with any spirit if the patient happens cloth, and especially those who are not pigmented with pigmented skin. So many of international patients, we face this all the more. If they had been on the pool of fluid. So whenever you are washing, the way I showed you yesterday, washing the abdomen with povidone iodine, you should have both sides padded with absorbent mops and clear it off. Don't allow the patient to lie on a pool of any of these antiseptics throughout the time, say 2 hours or so. Later, there will be blisters and it can be horrible.
Sir, I feel, sir, what they do is they take whatever is the remaining one and then pour it on. That
Bless
is
it.
That is the main
yeah,
problem.
that's the usual practice. Bless finally with this one, whatever
with
is
this one.
remaining.
So
Yeah.
why should I waste it or why should I throw it off? They just take it, and that's the policy I feel land you pick up as you do it, because you may have a small abrasion somewhere or a skin lesion that you will identify post cesarean section, and they will say that it happened because of your
No,
procedure.
I remember yesterday somebody said that they will close the Suja said, peritoneum herself. Always like that. No, I think the principle is accepted, but then we have to get the next ones also. So there has to be a transition. You may supervise somebody doing and then finally hand it over. Similarly here, painting, if I say that I will only paint, then there are so many other things I have to do in that time. So I think we have to make them learn, impress on them. Obviously there will be some problems in the transition phase, but I think they also have to come up. That's what I would think. But Uma, your point about I think you only mentioned the painting aspect, about the painting. Yesterday we had the same discussion. You know, the two areas in abdominal surgery that we have to be careful about, the umbilical pit. I always say that some umbilicus will be so deep that they may have the dirt accumulated from their baby days. And the other thing is the groin. These two areas have to be specially cleaned. Okay, next one.
Another question is to you, sir. In the breech session, do we have to put steroid cover in place before attempting ECV at 32 weeks?
No, I don't. See, having attempted so many and looking back, how many complications we had at 32 weeks versions. So we don't take it as very serious or associated. In fact, I should remember Professor Maladi, our late Dr. Maladi, who was my teacher at Calicut early days. Then she used to do the version right in the OPD. You see, it's a breach. Whether it is 28 weeks, 32 weeks, turn it then and there. 36 weeks also the same thing is possible. But of course, the clientele that we get these days are different. The IT professionals and all that, with all the fat over there and then never moving with the rigid abdomen and all that, they won't relax. Whereas the other ones that madam was doing are the working class women where they have thin abdomen, no fat and all that, you can easily turn it. So my point is this, earlier you do, easier it is, more successful, less complications. Later we do, less successful, but with more complications. That is why I am suggesting, when you get it 32 weeks, why not do it? Again, the whole policy of this conference is we are not to dictate any particular change to anybody. You think about it. If you feel there is a point in it, take it. Okay, next one.
What if baby again goes back to breech at 34 weeks?
Again, turn it.
Will Piley's forces be enough for after coming head in breech?
Yeah, see, Lakshmi very clearly told you, you are not going to apply the forceps until you see the hairline, the nape of the neck. And in that case, the Piley forceps is enough. The shank length is less, but still that is enough to apply in a case of after coming head. You don't need the Piper's forceps. I don't know how many of you would have seen a Piper's forceps. Piper's forceps is such a long one. It was devised at a time when they used to bring the head from the brim of the pelvis. At that time, cesarean was not available. So they have the double curve, a perineal curve, pelvic curve, like that. The ideal Pipers, I am sure some of your old institutions may have it for the museum to harass the PG students when they come for the examination, but never use it, isn't it? We don't need the Piper's forceps for that. If you don't have the Piley forceps, if you have the usual axis traction, you may still use it because the shank length is more, but then my hesitation to use them is they are much wider.
Then can we do double marker in twin pregnancy as a routine with NT?
Why should we? I don't know. I mean, as a routine. I don't know. Twin pregnancy.
Twin pregnancy.
Yeah, oh, sorry. I am not the one to answer that.
Yeah, you can offer first trimester screening. I don't know if Bijoy is here, but you can offer. You just have to indicate that it is what kind of twin it is, and you can offer.
Then in breech, preterm baby delivered, head caught inside the cervix, around the neck. What to do?
Classically, Dyerson incision is the one they talk about. That is, you incise. You can do at 3 o'clock and 9 o'clock, or at 2, 4, and 7 and 9, 4, like that. But the one I showed, the second one, I think I did not show you that. The trapped after coming head. Exactly this happened. Cervix was fully dilated, but the process of delivery was a bit slower, so the cervix gripped the neck, and I had a problem. That is the video which I think I could not show you the entire thing. That's what I said. It took about 6 minutes to deliver the baby, but the baby was fine. There, I could negotiate the blade between the cervix and the baby's head on both sides and deliver it. Not the first time, but the second time. And baby was fine. But often it may not be possible, especially because a footling baby is the one which causes this problem. Very often they are preterm. Very often they are not fully effaced and dilated. You may have a thick cervix, and that if it grips, when you cut it, you have to cut too much. So, yeah, if it happens, sometimes that's your bad luck, but let's hope that it doesn't happen. But this is an option. If it's a thin cervix yielding, you can even negotiate a blade. That particular patient I'm talking about, unfortunately, did not have even epidural. Before that, she just fully dilated. Then only we found out it's a breach. So we had to go ahead. But she was very cooperative.
Thank you, sir, and all the members of this session for giving the value, advice, and comments. Thank you.
Thank you very much. And I should say, Deepthi, I hope the messages that you wanted to convey about the main message that she said, that in hospitals like, the JCA accredited 5-star hotels and hospitals and all that, they may have people to look after your aseptic things and all that. But at the end of the day, it boils down to us being the infection control officer as well. If not taking the lead, at least you should be looking around and seeing. That's the message that she was trying to give you. Whether it is clean and all that, every day people will not come, but you know. And once they know that you watch these things, cleaning will be better. I thought that was the message that you wanted to give. You
Yes,
want
sir.
the
Thank you,
obstetrician-
sir. Welcome back to the post-coffee session. As I have told you earlier, I have given you 3 more minutes for the coffee. We are starting now. We are starting with the session, Acute Collapse. And the lead discussant is none other than Dr. Sangeeta Menon, the organizing secretary of this conference. As